The company is Employer Advantage Healthcare Solutions. My business partner is a physician. What we wanted to come up with, frankly and simplistically, was an approach that self-funded employers could use for the first time ever, maybe, to work directly with primary care in order to enhance their benefits and lower their spend. How can that be? Well, this is based upon a little opportunity I had back in 2005 with Cornell University to create, when I was working for a hospital, local community hospital in upstate New York, to create what we called the Cornell Program for Healthy Living. And after experiencing 12% year-over-year increases in their self-funding spend, 18 months into the Cornell Program for Healthy Living, we reduced the aggregate spend by $1,500 per employee per year. So we took a step back and said, whoa, wait a minute, I think we got something here. I think we discovered the magic pill, which is primary care. And so what this will describe is the business case for working with primary care in as direct and unfettered way as humanly possible. So the first message we share with self-funded employers is it's your money, it's your choice, it's your decision. You can either buy healthcare quality or you can buy something that's not. It's your decision. We offered up then a business model that would help them ensure that what they were going to buy was quality, starting at the primary care level. So we describe it as all about the alignment. How does it look in your community? So we simplify the conversation for self-funded employers and say it's all about primary care accountability. If you're working with the correct community of primary care, some really fun things can happen. We demonstrated that with Cornell, and we continue to demonstrate that today under the Employer Advantage banner. We share that under the right circumstances, primary care can have a fun relationship with the specialists and hospitalists that they share their patient with. We try very hard not to say refer the patient, because we want the employer to believe, because we have found primary care that really wants to be accountable all the time. Even when the patient's not in front of them, even when the patient is being cared for by a specialist. And we then ask that they work with us, a unique community of specialists and hospitalists that really know how to establish great working relationships with facilities, hospitals, and other providers. So that at every point in the effort, it's clear who's accountable for what, and everyone is accountable to the primary care physician, who in turn is accountable to the employer for the cohort of patients that he or she is caring for, so that there's no confusion as to who do I talk to about this. How do I improve that? Well, you talk to the primary care physician who is caring for those patients affected by whatever it is that you're trying to improve. So then we help the employer understand that we're talking about a good old-fashioned business-to-business relationship with primary care. Some call it direct contracting. We prefer to think of it in terms of establishing the primary care physician as the purchasing agent on behalf of the self-funded employer. So, and then flood that primary care physician with the kind of information they need and arrange that with that primary care practice so that they look a little different than what most might be used to. And I've got an even deeper dive into this. But we think it's really the process excuse me, that needs to happen to prepare for population health, because the primary care physician can't do it by themselves. And one of the things that we work toward with the self-funded employer is to liberate the primary care physician from what we refer to as Medicare medicine. And we mean that in the most derogatory sense. Because under Medicare medicine, the practice doesn't get paid a dime unless the physician's in front of the patient. And no offense, doctors, there are times where you're not the best person to be in front of that patient. That patient will have stress, diet, exercise, and sleep issues. And as skilled as you might think you are, you're not that skilled in dealing with certain of those issues. Now, you need to be accountable for the messaging that goes to the patient, but you may not necessarily be the best person to be in front of the patient. And that's where nursing comes in, for example, who know how to teach and know how to look for the return demonstration. We think there needs to be an organized fashion, so an arrangement so that the practice can genuinely take care of a population. And so a subset of the population works with one team, and another subset of the population works with a different team. For primary care physicians whose span of control capabilities is great, you can actually add a third nurse practitioner PA, an additional team. And now the practice can take greater numbers of people into itself and really address those needs. So when we share with an employer how this connects, we use 3 years of historical pay claims data for the employer to be able to see exactly what they've been spending their money on and exactly what their opportunity is in the first year and subsequent years. For an employer who is not interested in doing this more than a year, we say, well, good luck to you. We're going to go find someone who understands that this has to be a 3-year commitment. If you're going to change the way things work, we have to have at least a 3-year commitment in order for this to unfold, which is why we start with 3 years of paid claims data, so that the employer can see what the world has looked like for themselves, and we're able to establish some important benchmarks. So this is an episode treatment process that doesn't look at individual services, but rather looks at groupings of services over an episode of care. And again, I've got more information about this, but suffice it to say, we take the employer's bottom line monthly spend statement and connect it to, and I put this up here on purpose, poor Dr. Florence is a poor performing primary care physician whose episode of care delivery is in excess of the documented needs of the patient population. And because we risk stratify and risk score every individual patient in Dr. Florence's panel that have received those 45 episodes of care, it's adjusted for the needs of his patients. And so it's not a situation where the doctor can legitimately say, well, you know, my patients are sicker. Well, we've accounted for that in the case mix index. So this analyzes process of care, which an employer can relate to, because they've got business processes all day long that they're trying to make more efficient and effective. And so we make the connection for self-funded employers that you can do the same thing in your business relationship with primary care. And again, there's more information that's part of this. And if we were ever asked to sit down with Dr. Florence, we would help him see exactly which patients we're talking about. We would drill into this down to the individual patient level. The employer never sees patient level information. And this is our most mature working relationship with a manufacturer who invested in primary care while at the same time enjoying a reduction in aggregate spend. It is true. It's pay me now, pay me later. If you don't invest in primary care, you can continue to enjoy an increase in aggregate spend. As people, as patients, bounce around the healthcare system in an inherently ignorant way, responding to the most recent advertisement for something, believing or Googling it, if you will, treating themselves or managing their care with Google. Please forgive 2012. Our friends at Blue Cross Blue Shield of Tennessee lost some claims data. So it's not that it dropped like that. And we didn't feel comfortable trying to fill in a fudge number. But this is an employer whose experience had been flat for years to begin with because they were simply shifting all this increase to the covered individuals. They were giving them a raise in September and taking it away in November. This is a smaller employer who's just started, in the sense that their 4-year trend was like a little plane taking off. And they just were not, they had no idea what to do. And so what we did was introduce them to this concept. And for the banking individuals in the room, this is based upon payment in advance of care. So the primary care, in order to truly liberate them from Medicare medicine, using the employer's historical claims data, we calculated for that employer what a PM should look like, paid in advance, so that now the practice has maximum flexibility to align care with the needs of the patient population rather than provide care that they can get paid for. You talked about revenue cycle management. Trying to figure out what I can get paid for is a huge exercise. I had the opportunity to run a similar type of arrangement for a Medicaid population in upstate New York. And what we did was we were able to negotiate a payment in advance of care with one of the Medicaid claims, or one of the Medicaid carriers. And so we eliminated the billing staff, brought them around front, and doubled the number of support people that were helping the physician. So it's amazing if you can improve cash flow for primary care. Primary care now can afford to build that team we were talking about earlier and can afford to do some great things. And so there has been a steady increase on a monthly basis in terms of this primary care investment that's occurring for this particular employer. And they're happy in the sense that what they've at least done is stabilize from a trend perspective. For the future, what we would like to do is create the most simplistic measurement of primary care success that's out there. And the good news is our friends at the University of Oregon have done some really great work around what's known as patient engagement and activation. And what their research suggests is that a highly activated patient, level 4 activated patient, is inherently healthier and 10% less expensive to care for. And so in our business model, we are creating what we are calling the patient commitment level program, where the primary care team will accomplish two main things. They will create a clinical care plan that the patient has agreed to and signed, and they will create a wellness care plan that the patient has agreed to and signed. And for patients who are able to do that, and then achieve a set of personal goals for that individual patient, they can rise to a level of patient commitments, level 7. We've created a feedback loop to the employer without revealing any protected health information back to the employer. We are now sharing with the employer a scorecard that says, not only did your covered individuals enroll in this program, but your covered individuals are highly successful in this sense that they are very cooperative with the primary care team without revealing any of the issues that might be facing that particular patient. The employers that we've shared this with can't wait because it'll allow them to stop practicing medicine out of their human resource department, known as wellness programs. They will finally have an opportunity to install wellness efforts into a clinically valid environment. And all they have to do is create the right type of incentive, if you will, in order to get folks to become part of one of what we call these featured and favored primary care practices. Because that's the other thing that we've discovered, is that not all primary care is ready for this. But the good news is, if you risk stratify the population well enough, you don't need all primary care. So,
you say that again?
if you risk stratify the population well enough, you don't need all primary care. You just need the correct community of primary care. Because the team illustration I presented earlier, if you really expand it out, one of our clients is Union Hospital in Dover, Ohio, where they're able to treat themselves as a hospital, as an employer first and hospital second. They have created very robust primary care teams. The staffing ratios are remarkable in terms of the number of support staff per full-time primary care physician. And they are essentially selling themselves services and are paying themselves using the payment in advance of care model, so that the team is able to take in a population recognizing that 15 to 20% really need the time and attention of the physician, and the rest can be cared for quite comfortably by everybody else on the team. So, how'd I do? Questions? Comments? Sound too simple? Sound too good to be true?
Well, I think your comment that not all primary care is ready for this is is a heavier statement than it may sound.
Right.
Because, I mean, I think it's valid conceptually and can take place. Problem is, we've all been indoctrinated, trained, we have our medical models, we have our intuition, and that all has to be undone. So
Yes.
I think that, that's sort of, that's probably the biggest obstacle.
Yeah, sure, you're absolutely correct, which is why we live exclusively in the self-funded employer space. It's easier to undo something when you're dealing with folks who've got simple needs in terms of, I want to provide the best for my covered individuals at the best possible price. It's a simple conversation from their standpoint. Yeah, because I've done time in the government space, and boy, I'll tell you, there's a lot to get undone there.
Well, I'm talking about the primary care.
Oh, well, that too.
Themselves, yeah.
No, that too. And that's why I use the phrase Medicare medicine, because I think that what has evolved there and the way physicians are compensated, I mean, you get half as much more if you write 3 scripts instead of none. That's nuts.
Question.
Yes?
Most areas you went into, are there private or employee or big groups where you carve out a subset, or is it certain groups you take the whole group in the area? I mean, what do you look for?
Oh, we need at least 500 employees in a given geography for this to work and work well.
But who do they work with? Like, if you came into here and one of the big health networks in the regions you're looking to do this with,
Right.
they carve out a subset of their population of...
Yeah, based upon the
primary care
data.
doctors?
For example, if we did a data study for PNC, you would see, we would share with you the actual names of doctors and show you, based upon the documented needs of your population, how well these doctors were performing. I got summoned into an IPA office a couple of years ago, sitting across from the executive director, and he said, "You know, you're cherry picking." And I said, "And your point?" Why do we want to continue? I mean, again, some of us are a little bit more energized in terms of driving change, because after 33 years at this, I started out with a small little company in Massachusetts called Blue Cross Blue Shield. I don't know if anybody's heard of them. And so I have been on both the payer and the provider side for the past 33 years, and have seen it from both parts of the conversation. And for self-funded employers, it's their money, it's their decision, it's their choice. Why do they want to buy inefficient and ineffective care, or what I affectionately refer to as healthcare crap? Why do you want to buy that if you don't have to? And I believe that there is an opportunity here, and I think primary care is absolutely the key to this conversation, because they're the ones that know. I mean, my business partner is a pulmonologist by training, sleep medicine by trade. His message is, good doctors don't need guidelines, bad doctors won't follow guidelines. Good doctors know other good doctors. So if you quietly but consistently illustrate the difference between high quality care and care that's less so to the person who's paying the bills, typically, they'll say, "Oh, I want more of that." We just completed a data study for an employer who's located in 5 states. Everywhere except Talladega, Alabama, we were able to identify the potential for high-performing primary care. I don't know what's going on in Talladega. I've never been there. I understand it has something to do with racing. But the bottom line is, if the employer is presented with a workable solution, why not, number one? And number two, in this employer's case, if they could simply move people away from lower performing primary care, there was $1 million they were looking at right there, just by getting people with better performing primary care. And so, why wouldn't you? Our message is, it's not the employer's job to rehab bad doctors. It's the employer's opportunity to help identify great doctors.